It's been a wonderful conference, actually. I've learned a lot so far from all the speakers, and particularly the technologists in the morning. They showed lovely cases. I think that just shows that there is tremendous enthusiasm. So this talk really is for the technologists and for the students who are here. Some of the pediatric cardiologists who are here may find it a little too basic. So I'm going to take you through a journey. I'm from Amrita Institute. This is the picture of Amrita Institute. Sweta, you've been here very recently, but it didn't look like this many years ago, and it's grown, as you can see. And this is the team. So it's not the buildings that make institutions, it's the people that make institutions. And I'm very fortunate to be a part of an extraordinary team, and I don't see myself separate from them. So all of them together, that we work to deliver pediatric cardiac care. My journey started in 1989, when I joined DM at All India Institute, and there is relevance to this history that I'm going to talk to you, because I've seen the development of echocardiography in this country right from its formative years. And I have to point out Dr. Savitri Srivastav, who was in some ways the grand mistress of echocardiography in this country. She started M-Mode, amongst others who started around that time, but she took it further. She did 2D echocardiography. She brought in all the technologies that I'll talk to you about, but she really inspired me. But equally inspiring was Dr. Tandon, who introduced me to pediatric cardiology. So together I joined the DM course in 1989, and I spent the next 6 years there. But during the period, I saw the evolution. So we started with M-Mode. 2D had already come by the time I was a student, DM student, but it was just 2D. It was just 2D with mechanical probe. It just could do pulse Doppler with great difficulty. And for continuous wave Doppler, we had to use a separate pencil probe. And it was very nice, actually, because you used to use the sound to direct your pencil probe and get the right color. I'm sure the very senior people here can relate to that. And that taught you a lot about using continuous wave Doppler correctly. Then color came and changed it all. I'm showing Bhat Simpson because blue is away and red is towards. But essentially, phased array technology came, and then transesophageal echo came, and then there's been an explosion of growth of echocardiography that has really been very interesting to watch. But I think we need to put the technology in perspective of the lots of other changes that are happening in today's world. This was the picture of Amrita Institute of Medical Sciences when I established the program. This is Aarti Hejmadi, who was there at St. John's Medical College. I think Ravi Narayan will remember the first workshop we did. This is my first echo technician whom I borrowed. She was actually a janitor in the floors. I didn't have a technician and I had to bring her. And she turned out to be the most extraordinary echo technician that I could work with. Amongst my first trainees, Dr. Mahesh Bhat, and you can see the 5500 machine that we used with. We used to warm the jellies with. We continue to still do that. And that's how we started it. But going back, what taught me echocardiography really was my 2 years at Boston in 94 to 96. This is a picture of Boston Children's Hospital that Dr. Locke's wife drew and presented to me when I left. But the 4 people who taught me echocardiography are somebody we should remember. They are the masters of pediatric echocardiography, but the foremost among them is Stephen Sanders, who laid out a system for pediatric echocardiography. And some form of it you all follow today. That systematic way of doing pediatric echocardiography with understanding of anatomy, that whole system was laid out by Dr. Stephen Sanders. Dr. Tal Giva was the master of quality in imaging. So he is the chief of Boston Children's today. Stephen Colan is one of the most brilliant physiologists I've come across. He's a PhD in physics. He's also a PhD in computer programming, and he is also a brilliant pediatric cardiologist. He actually put the entire system for functional assessment in Children's Hospital, and I was fortunate to work with him. Mary Vander Velde was also an extraordinary echocardiographer who did fantastic fetal imaging, who brought in fetal echocardiography also. So they laid the foundations and they taught me some things. I'm sharing those lessons with you. It's very simple, but it's important to say that. Do not compromise on image quality. So even today, image is everything. If you look at what happened, what's the most significant advancement in echo, I think it's just persistent. It's just this incremental improvement in image quality that, especially from a pediatric cardiologist point of view, it's the most important thing. So don't compromise. And Dr. Talgiva would spend hours to try and get the finest image. They would image the coronaries before every arterial switch. They would be sure of an intramural coronary, but they would really work hard on those images. So that's what I learned there. This is an unfortunate habit. I've seen people put color very quickly without dwelling on the 2D. So they would dwell on the 2D and understand that from a very intuitive perspective and then put color. And that made a quantum difference in your understanding. I just don't see that happen these days. In fact, you have this dual screen thing. You put and you get 2D and color on the same screen. You don't give enough attention. You don't give undivided attention to 2D imaging. Understand basic anatomy and physiology. Everything stems from it. So the more you understand it, even today I'm understanding physiology and anatomy. The lecture on pulmonary vein pressure, Doppler taught me lots of new things today. So don't ever deviate from that. And then I think that lecture was very good by Dr. Sunil Bohra. In that, the principles of Doppler, you have to understand them from a very fundamental perspective. Only then you can apply that correctly. And then, no matter what you're asked to do, and if the patient's clinical context is important, it's very important to make clinical correlation, but your echo has to be comprehensive. Even if your clinical question is very limited, your echo has to be comprehensive, especially for pediatric cardiology, because there are things that you will pick up that you wouldn't have suspected clinically. So no matter what your clinical question is, you have to be comprehensive, but once you've made a diagnosis, go back to the clinical situation. So that's very important. And then most importantly, follow a systematic approach. And that's what I learned. I brought back that whole sort of philosophy from Boston, came and did that in Amrita. In 2001, I think I remember I did an echo workshop where we did this whole review of this clinical approach. And that changed everything, because until then we were cathing little babies for VSD, babies with tetralogy, babies with relatively, easy to identify conditions, and we would subject all of them to a diagnostic catheterization for nothing at all. So we stopped doing that. And that was a big change that happened in Amrita when I came in, that we just almost eliminated diagnostic cath in pediatric cardiology. So that was really a big, big change. And this is what the pediatric heart program in Amrita, the net result was that we could just dramatically increase the surgical throughput, because we were not having to have this barrier of cardiac catheterization. So many children could get operated. So then I essentially, what I taught in that whole workshop was the rules for congenital echocardiography. I'm just going to go through them once again, because that will set the stage for what I'm going to tell you after that. The rules of congenital echocardiography for congenital heart disease. 1, you have to follow the same systematic approach, disciplined approach, no matter what the lesion is. So there is no disease-specific approach. Sir, how do you do an echo for an VSD? Just tell me those 4 views. No, I just want to know how to identify VSD. Or just, if there is an ASD, sir, you just tell me about the margins. I want to know that. That doesn't work like that. You have to do it thoroughly every single time. And you can do it reasonably quickly. But you have to have the same approach. So this is the highly controversial thing that this morning, I think the technologist from Narayan was alluding to, which is anatomically correct display. She was being very defensive. She said, oh my God, I'm sorry, sir. You guys are seeing, we are seeing upside down. No, this is the right way to do it in congenital heart disease. I'm being unashamed about it. Because you look at an X-ray that way, you look at an MRI that way. Why do you have to look at the echo upside down? Doesn't make sense. Only then you stay oriented. So one of the reasons why it's easier then to become so well oriented, particularly in subxiphoid view, is to show it correctly. So I'm not ashamed about it. That's the way to do it. Then it's not just to stay oriented. Now, once you displayed it correctly, you must know where you are. You must know where your transducer is, where is it pointing. So that kind of mindfulness in your echo is very important. What is right, what is left, what is anterior, what is posterior, what is superior, what is inferior, you need to know. You got to have that compass in your mind all the time. So that works very well. So even if it's dextrocardia, you don't change the orientation. I remember when I learned before I went to Boston, we were changing our orientation, completely left us confused. So don't change that. And I'm sure all this you guys do. And then it's not just staying oriented with your position, but it's also about how you move your transducer. Those movements have to be conscious. Now that's where the adult and pediatric worlds are slightly different, in that we depend a lot on sweeps. We move from right to left, from inferior to superior, and we get our information and we assimilate that information and recreate that anatomy. That is what we do. Now that is something which is very important in pediatric cardiology. So in this example that you're seeing, this little baby, where we're doing a subxiphoid echo, we're doing it in the sagittal plane, we'll move from right to left very consciously. We'll come back from left to right. With the dextrocardia, we move from left to right and then come back. So it's very important that we're making these sweeps and we know what we're doing. So here's that example of the subxiphoid sweep that I'll again come to. But we move from the atrial septal plane to the perimembranous plane to the RVOT to the apical cavity. So that whole sweep we have to be conscious about. And then you have to have a mental checklist. So checklist will have variations, but you've got to finish all those elements. And those elements are position, situs, systemic veins, pulmonary veins, atria, atrial septum, AV valves. So we got to finish this. And even today, I find myself consciously having to do this. Sometimes I forget it because we get casual with times. So it's very important that you get this whole checklist. And after you've done the checklist, the physiology should make sense. So there has to be internal consistency amongst all the elements within the echo. And this has to be consistent with the clinical picture. So to put the rules together, systematic approach, anatomically correct display, stay oriented, make conscious movements, and complete the checklist, but expect the unexpected. You can always have something new. That's the beauty of pediatric echo. You find things that you've never seen before. You really learn from that, and that makes it exciting, and that's what keeps us going all these years. So, in fact, with all this, we really took echocardiography to another level in the years that I spent so far in Amrita. And by 2008 and 10, we had been starting to do pretty extraordinary things with echo. One example was to guide the surgeons through, before 3D echo came in, through this en-face reconstruction of VSDs that we could do for complex VSDs. I'm just going to go through really quickly how we used to create a roadmap for the surgeons, tell them the likelihood of occurrence of heart block, where the bundle is going to be, where can we expect the VSD, how do you open up how do you approach the VSD, whether you need to detach the septal leaflet, etc., etc. And we could really give a beautiful roadmap, and we started to get very, confident about echo, and we felt that, why? This is like everything. You don't need to do most other imaging. But then we were wrong. With time, we realized the limitations of echo. And they're important. We have to acknowledge those limitations. Echo is poor at extracardiac anatomy. And there are times when it really matters. So if you have a heterotaxy with the total anomalous pulmonary vein communication, you can actually miss it. You can be fooled. And distal aorta, branch PAs. So that's where it comes to, that there are limitations. Complex anatomy, where you need to communicate and show the complex anatomy to the surgeon and guide them towards surgery. That process wasn't easy with echo alone. Of course, 3D echo made a difference. Here's an example of a DORV with a doubly committed VSD that I'm showing. But even with the 3D, I couldn't do it, so I had to draw the diagram for the surgeon and tell them where the VSD is. And when you do all this, you can make errors. And I used to make a few errors, and I have to acknowledge that. And our patients started to grow up. Grown-up congenital heart disease happened, and images get worse and worse and worse. Echo is not good at RV assessment, really. And we realize that, and there are so many limitations with echo's ability to understand the right ventricle. No matter what technology has come in, we feel that there is limitations there. It's not good at post-operative anatomy. It's not good in redo situations. Doesn't tell you about adhesion of the right atrium to the sternum. It's not good at correlating lungs and airways that are compressed by vascular structures. So lots of limitations, and you have to come to terms with that. And that's when emergence of MRI and CT happened. So the two colleagues of mine, this is Mahesh, who's a superstar really in terms of what he has achieved for imaging. And really, I feel really blessed that somebody like him has been working with me. And then, of course, Rajesh Kannan is our cardiac radiologist who has partnered and collaborated with us beautifully. So MRI gives you a perspective, obviously, that echo cannot. You see such extraordinary detail. It took this whole thing to another level. Mahesh decided to move to 3D imaging. And we set up the first 3D printing lab in the country and perhaps in all of Asia, where we really started to print out our hearts using the entire 3D data sets that were created from CT and MRI. But then he didn't stop at 3D. He went on to virtual reality. And with virtual reality, you don't have to make these models. Instead, you could use the virtual reality process where the consoles and with the headsets, you can actually experience in an immersive way what the heart is like. And with that, you can get inside the heart. You can look and understand those images. And with this, the whole vistas of imaging have changed completely. And that's been a most fantastic development. But is that the way to go forward? With every new advancement, do you just get rid of your old technology? Is that correct? Like how we've got rid of clinical exam just because we've started to do echocardiography. So that's where I thought we should look at this whole thing again. And not just me, Mahesh thought of it. So Mahesh said, listen, let's use this whole process to teach echo in an accelerated fashion. So now that's what he started to do. And that's made a quantum difference to the learning of our fellows. The learning curves of our fellows and our technologists is just supremely accelerated because now we use extended reality to do this. Again, before we do that, I'll tell you what VR is capable of achieving, which echo is not, routine echo is not. Here is an example of a very complex transposition who was rejected until the age of 7 years. Somebody had done a band and they forgot, they said, we can't do this. It's a transposition with VSD with what looked like a straddling mitral valve, but nobody could envisage how to repair. So Mahesh took this image, created a VR reconstruction. He could show the VSD to the surgeon. He could show where the papillary muscle was attached. We could visualize a plane for the patch. And then, to cut a long story short, we could offer an arterial switch. This was a doctor's child who had gone to a number of institutions who did not want a Fontan, and we were able to do a full arterial switch with keeping the straddling mitral valve on the left side of the patch. So it was a fantastic achievement, but couldn't have happened without VR. But that's essentially showing you the scope of VR. But what we did then was to bring it back and demonstrate it how we can use it for echocardiography. What Mahesh does is that in fact, this lecture should be maybe next opportunity, you should invite him to talk, because what he does is phenomenal. He takes this, and lots of this software is homegrown. He's created a whole system for it, where he actually takes this, marks out the whole area using these very advanced tools, and literally builds the heart outside within this whole system that is created using this and then he's able to pick up the heart, and you can actually have a hologram of the heart. What he did 2 days ago was that we were able to actually have a virtual meeting with people from all over the world who were able to interact as avatars and look at these hearts in real time. But using this very powerful technology, we can now make very accelerated learning with echocardiography. And this is going to happen very quickly. Today he's wearing these very fancy headsets, but tomorrow it could just be a simple goggles that will allow you to actually interact. And so we'll start. Now here is an example of a apical 4-chamber view that I'm going to show you. And I'm going to show you how it correlates with the standard echocardiographic images. So this is the apical 4-chamber view, and you start cutting from posterior to anterior. And I'm just going to freeze it briefly and show you how we start with this. So once again, so as you go posteriorly, you see the coronary sinus, and you can actually correlate that very well. And as you go progressively anteriorly, you can see the AV valves, then you can see the aorta. There you can see, and further anteriorly as you go on, you can see the right ventricular outflow tract. Now this is just to show you, all of you are super familiar with this, nothing new in this, but to a student who's seeing echo for the first time, this is really rapid learning, very fast learning and understanding the images. Parasternal long axis, again I'll repeat the whole process for you. And in the way we do it in pediatric cardiac world is that we sweep from the neutral position where we see the aorta and the mitral valve, and then we sweep upwards to see the pulmonary artery and sweep downwards to see the tricuspid valve. So that's exactly what he does. And this is from the neutral position. You can see the extraordinary correlation and the details. Of course, it's very intuitive for all of you, but I'll start by just showing you so that you can understand how easy it's for the first time student to pick it up. Tricuspid valve and outflow tract. But this is where it really starts to matter. Subxiphoid sweeps. Here is the subxiphoid 3D data set. And I can start by running it for you. So you can start, you see from below, you start sweeping up. You start first the atrial septum, coronary sinus, and then you start going up. Start to see the aorta, both the AV valves. Slowly go up, and then finally you end up with the right ventricular outflow tract. So that again, the subxiphoid short axis or sagittal sweep, that is not so obvious for a lot of people. Very difficult for some of the beginners to understand, but super easy once you start looking at these images. So we'll start looking at it now, and I'll show you how this is going towards the apex, but once you come back, it'll come up very nicely. Of course, he worked very hard to make these slides for me, Mahesh. It just takes a second. So that's the region where you see the membranous septum. That's when you see the outflow tract. That's when you see the ventricular cavity. And that's when you go towards the apex. You can really quickly understand how the whole thing pans out on echocardiography. And this has been a fantastic advancement. Suprasternal view, again, very useful. How you can, this is parasternal short axis view, where you can see this anatomy, and again, you can see this remarkable ability to correlate this anatomy and show it in real time. The ductal view is something that people find it very hard to understand. So here again is an example of how you show the duct in the long axial view. And you can see how by slightly rotating this image, you get the exact replica of what you see here in the ductal view. A very useful view for us pediatric cardiologists when we look at the patent ductus in the long axial view. Short axis you're all familiar with. Suprasternal, you can see that again, where you see how wonderfully you can actually see this aorta in the long axis, and you can open up the branches and understand it. Of course, it's very easy to show the right arch versus left arch and how you image that. I don't want to get into the details, but this is really wonderful in relation to the neighboring structures such as trachea. So how has it impacted the learning curves of our trainees? We actually decided to measure that. So we did a evaluation, and this is a wonderful paper that Mahesh has written, where he is, and this actually won one of our fellows, one of the awards at the CSI conference, where we took 9 participants and pediatric cardiologists with 10 years experience, surgeons with 5 years experience, and fellows in training. And we looked at their learning curves. So step 1 was to understand the sectional anatomy using raw images like CT and echo. Second was to look at 3D models, and the third stage was to look at VR. And they found that with VR, the fellows in training were able to achieve an accuracy close to that of the consultants with 10 years experience. So this is a game changer. It is a disruptive technology that's going to be completely transformative. And that was what's very exciting about it. So to conclude, newer tools, extended 3D imaging, VR can greatly accelerate acquisition of a mental roadmap so that you know exactly what you're doing. When you drive a car, it's so intuitive. You don't really worry about what's right, what's left. It's all within your mind. That's exactly what's going to happen with Echo. But, and congenital heart anatomy is going to be demystified completely. That mystique that surrounds all those fancy conditions can be completely eliminated because it's all there in front of you. But this should not compete with our existing technology. It should complement. So I'm just going back, ending with the words that Dr. Nagaraj Desai actually said. I'm going to reiterate the same theme, and I don't think it will be boring. I'm inspired most by Dr. Tandon. You know, Dr. Tandon used to, every end of the day, at the end of the cardiac catheterization, he will go back and listen to all the patients who have been catheterized and write down his hemodynamic assessment and compare his hemodynamic assessment based on what he listened to with the final CAT data. So he used the advancement in technology to become a better and better clinician. Whenever echo diagnosis used to challenge his clinical thinking, he'll go back and listen and get better. There are times when his clinical exam used to make us do echo once again. So I can never forget that, as I would have to end with that kind of a message that you cannot forget the clinical context. You always have to build on the clinical context. Thank you.
Good afternoon, everybody. Respected chairpersons and dear delegates. I had listened to Dr. Krishna Kumar when I was a student, and I have been listening to him since the past 20 years. It was like a fantasy world. Whatever we saw, it was like a fantasy. And my topic is going to be a little boring, and I have made it very simple. How do we evaluate LV function in the setting of arrhythmia and dyssynchrony? As we know, when there is onset of tachyarrhythmia, there is a compensatory phase where there is going to be activation of the sympathetic system. Initial first week, probably the LV function is going to be normal. But the next 1 to 3 weeks, we start deterioration in the LV function. And when the arrhythmia persists for more than 3 weeks, LV failure is going to set in. So arrhythmia-induced cardiomyopathy is a terminology where arrhythmia is the sole reason for the ventricular dysfunction. We call it as arrhythmia-induced cardiomyopathy. Both atrial or ventricular tachyarrhythmias or even frequent ventricular ectopics can result in left ventricular dysfunction. It can partially or completely reverse when we control the arrhythmia. And when we talk of tachyarrhythmia, the most common tachyarrhythmia is the atrial fibrillation. It is the most sustained arrhythmia among adults, associated with sustained morbidity and mortality, affecting around 2 to 4% of adult population. And it's often associated with heart failure, and we know the risk of cardioembolic stroke. Even the focal atrial tachycardia and incessant tachycardias are also more prone to develop ventricular dysfunction. So what happens in AF and why there is onset of ventricular dysfunction? There is loss of atrial systolic activity. There is reduced preload. Because of the RR variability, there is modification of the ventricular filling. Accordingly, the LV output is also going to vary, and the LV contractility is also affected by the pressure interval relationship based on the Frank-Starling equation. So whenever there is increased heart rate, it is going to reduce the LV filling time, and there is loss of AV synchrony, which is associated with impaired diastolic filling and the increase in the diastolic atrial pressure. So in heart failure patients with sinus rhythm, in a study, it was demonstrated that LV ejection fraction is closely related to clinical outcomes, with each 5% lower EF increasing the risk of all-cause mortality by 24%. But however, in patients with AF, the relationship of EF with clinical outcomes is less substantial. They demonstrated only a 9% increase in mortality for 5% lower AF. This reflects the higher variability in AF patients. Is it really true, or is it the improper assessment of LV function which we are doing in AF patients? So AF and assessment of ventricular function, why is it important? This is to enable clinicians to provide appropriate therapy and improve the prognosis, that it is essential for us to understand the systolic function and assess it properly. And these LVEF thresholds guides our management decisions, and this highlights the importance of understanding the accuracy and the validity of systolic function assessment. So when we want to assess, assessment is performed in every cardiac center globally. This we should understand. But there is very limited scientific data on measurement quality or validity. Why does this happen? It happens because there is beat-to-beat variation, which can be a detrimental factor to the reliable and reproducible assessment. And comparison of validity and reproducibility between various methodologies we have, like echo, MRI, cardiac CT, the scientific data is extremely limited. It is very challenging to assess the LV function because we have difficulties in acquiring diagnostic quality images, and we have difficulty in interpretation of the results as well. The assumption that parameters used to quantify dysfunction in patients with sinus rhythm have the same validity in AF may also be incorrect. But still, LV ejection fraction continues to be the most used parameter in clinical practice. But due to the varying RR intervals, the results of this volumetric and functional measurements vary with different chamber filling properties. The variability of systolic function is reduced if the preceding RR intervals are quite long or similar in length when we reduce the heart rate. But is it easy to achieve this? So how do we assess it? So we are having 2 or 3 methods to do this. Either we have to average over several cardiac cycles. This can presumably depict the real functional status. So we are expected to average 5 to 10 beats, but are we able to do this in routine practice? If you see the ECG gating in the lower panel, you see that you have shorter cycles, you have few longer cycles, RRs are wide and RRs are narrow. So definitely the filling is going to vary with each cycle, and we are expected to average at least 5 to 10 beats. But it may not be feasible. Then there is suggestion of one more approach, which is called the index beat approach. What is this index beat? You take only one beat, but you select a beat which is the most appropriate, where you expect a normal LV filling to happen, and assess the usual parameter. So the measurements with longer RR intervals represent the state of best possible LV contractility. If you look at the lower panel, it is the 4th beat, which has the longest RR interval. Then the GLS, longitudinal strain, overcomes many limitations of the volumetric method. In fact, we can pick up subclinical systolic dysfunction. If you see the right picture, in a patient with AF with fast ventricular response, the deformation you can see, and following the cardioversion, you can see the deformation. GLS has also been able to provide some prognostic information. Probably it is more reliable method of assessing systolic function. And GLS has independently shown to be associated with embolic stroke among atrial fibrillation patients. For the risk prediction, a GLS cutoff of minus 12.5% has been proposed. Then the tissue Doppler, which is more commonly used in the assessment of diastolic dysfunction, this has also been suggested. Measurement of S prime at the junction between basal myocardium and the mitral annulus. So it is not the lateral annulus, it is the medial part. It can be an early marker of subtle LV systolic dysfunction, and it is shown to have an excellent correlation to left ventricular ejection fraction. And it is simple to measure and with a good reproducibility and feasibility. And it is also shown to correlate strongly with the ratio of pressure change in LV cavity. Then the M mode, which is considered to be like obsolete in the measurement of LV function. We use more of TAPSE to measure the RV function, but here this is also suggested. It is called as MAPSE, where this is a direct, early, and a sensitive index of LV systolic function, even in the presence of preserved LVEF. So it indicates longitudinal systolic function. 12 to 15 is the normal cutoff. It can work like a significant independent predictor, and more than 7 mm indicates severe dysfunction. But one should understand that all these parameters show significant variabilities in different heart rates. So what's the practical approach? So there is an editorial which says that, evaluation of systolic function during atrial fibrillation, is it reliable? What does the guideline say? Guidelines, basically, they suggest at least 5 beats in AF should be evaluated, but it is just a consensus opinion. So we need to make a distinction between functionally relevant status from a best possible hemodynamic status. Functionally relevant status we are doing by averaging at least 5 to 10 beats, and the best possible hemodynamic status is by taking the longest RR interval. There is one more method which is being suggested. This is RR indexation method. You are indexing the assessment to the RR interval or its square root, GLS by RR or GLS by square root of RR. And this is being reported to be a prognostic marker of outcome in patients with AF and heart failure. This is a study where they employed STE and GLS analysis. GLS has a high resolution and it is especially useful in tachycardia. And this concept of frequency correction was proposed by Olson. So this picture clearly depicts, this is recorded in a patient who had AF with heart rate of around 115 beats per minute. You can see how the EF has varied. It has varied from 14% to 48%, and GLS has varied from minus 1.5 to minus 14.2. So much of variability. And if you look at the picture of the GLS bullseye, the best possible deformation is shown in the cardiac cycle 4, where you have a long RR, and with a short RR, short cycle in the cycle 6, the least deformation. So it can vary to this extent. So definitely 3D echo scores over these parameters. Evaluation has a higher accuracy. You can overcome foreshortening, and we can also perform the measurements. So this is a study where they compared various modalities to assess the LV function in arrhythmic patient. They compared MRI, with echo, with CT. And what was their conclusion? The validity of systolic measurements in patients with systolic function measurements in patients with AF remains unclear due to the paucity of good quality data. What happens in all these studies is that they collect the images with the best quality images. So is it easy to get a best quality image in AF? Finally, none of these are well validated. They concluded that global longitudinal strain is superior to LV ejection fraction in predicting cardiovascular events. So GLS is proven to be as accurate as 3D echo, and it showed no correlation with the change of heart rate. And strain rate is less load dependent as compared to strain. But we have to have different parameters. Definitely frequency independent parameters like corrected GLS or strain rate imaging are more reliable. Then comes the diastolic function assessment. I was discussing the systolic function. It is also really challenging because of the same issues. And there is the enlargement of left atrium which is expected in atrial fibrillation patients. That also adds on to the problems. But definitely we have guidelines regarding this. So you have guidelines given by both ASC and the European Association. Peak acceleration rate of mitral E velocity more than 1900 centimeter, IVRT less than 65, and deceleration time of pulmonary venous diastolic velocity less than 220, and E by velocity propagation ratio of more than 1.4, and septal E by E prime ratio of more than 11. These are the values given by ASC. And this is a study by Khan et al. Where they have studied 148 patients, and they have proposed a two-step algorithm which is also approved by British Society of Echocardiography. So in the first step, you are going to look at these 4 parameters: septal E by E prime ratio of more than 11, mitral E velocity more than 1 meter per second, E deceleration less than 160, and TR velocity more than 2.8. If all, 3 or more are positive, there is definitely impaired diastolic function with elevated filling pressure. If more than 3 are negative, it indicates normal filling pressure. If there is insufficient step 1 criteria, you are going to step 2. So what are the parameters you consider in step 2? It's the LA reservoir strain. If it is less than 16%, BMI more than 30, and pulmonary venous systolic to diastolic ratio less than 1, you have insufficient step 2 criteria, then it is indeterminate filling pressure. I think this is more user friendly. So what about the other arrhythmias, like even simple sinus tachycardia and ectopics? We have difficulty in assessing, where we have to use a sweep speed of 100 meters per second. And we know that in sinus tachycardia, there is fusion of E and A. So it makes our assessment difficult. We won't be able to assess properly the E wave velocity and even the ratio. But when you have a ectopic, you get a compensatory pass, which may allow you to measure E and A. And markers of raised LA filling pressure recommended in these settings, E by E prime of more than 14 has the highest specificity. The same thing is also recommended by American Society of Echocardiography. The most important is the E by E prime, which has the highest specificity but low sensitivity. What happens in your bradyarrhythmia like AV block or a paced rhythm or a bundle branch block, we definitely have difficulty because there can be EA fusion, which can create a diastolic mitral regurgitation. Here, markers, basically, the most important thing is E by E prime more than 14. LA volume assessment is also useful, more than 34 ml per meter square. And of course, the increased PA pressure. Then a few words about dyssynchrony. In dyssynchrony, what happens is a loss of a nearly simultaneous LV contraction. This can happen in a coronary artery disease post-MI, but typically represented in left bundle branch block or any other conduction defect. So in individuals with bundle branch block, what happens is asynchronous LV motion. This is basically resulting in earlier activation of the septal valve compared to the lateral valve. And we can underestimate the true LV function. So we have electrical dyssynchrony where there is prolonged conduction time. And in mechanical dyssynchrony, there is mechanical discoordination with disparity in the timing of contraction and relaxation of medial and the lateral valve, as you can see in this echo picture. So what happens here? Mechanical dyssynchrony can give rise to atrioventricular delay or interventricular delay and intraventricular conduction delay. And intraventricular conduction delay has a greater effect on the ventricular function. So definitely M-mode measurements are unreliable. The most commonly we rely on the volumetric methods of assessment. And there are algorithms which are used to determine volumes and ejection fraction by 2D echo, but they are all error prone because these algorithms are all based on geometric assumptions concerning cavity shape and position. Can we use global longitudinal strain? Strain as such, even in the absence of systolic dysfunction, it can be reduced due to dysynchronous contraction. Basal septal strain is often significantly reduced or abnormal. Lateral wall strain may be delayed but preserved. And there is difference in the timing of peak strain across various myocardial segments. So what are my key points? So assessment of LV function in patients with arrhythmias and dyssynchrony remains a challenging task. Multiple methods are needed for evaluating LV function, which may not be very practical in our day-to-day practice. ECG guided echo assessment is a must. All the methods have limitations. They lack reliability and reproducibility. Volumetric methods for assessment are variable and not always reproducible. Strain rate imaging, tissue Doppler and 3D are more accurate. Probably in future, some AI-based technologies would help us in improving the understanding and in proper evaluation of the LV function. Thank you.